I was surprised during my readings of prostate cancer and my experiences in clinic that there really are no treatment guidelines to help us manage patients who have a biochemical recurrence after radical prostatectomy. And patients I saw in clinic seem to be managed differently. Every patient with biochemical recurrence seems to be different. So in reviewing the topic, I found that there are really only a few natural history series which help guide our management of this clinical scenario. The first of which was published in 1999 by Pound. One thing I noticed from the natural history series was that patients with biochemical recurrence represent a very heterogeneous group of patients. Some progressed rapidly to metastasis and death, and some never progressed, having only a rise in PSA as the only evidence of the disease recurrence. So what I'm going to talk about is some of the articles which review or that have shown us which patients are at risk of progression of the disease. Probably PSA kinetics or PSA doubling time is the most important or most valuable factor in predicting progression of prostate cancer. So my talk is about patients who have a rising PSA after radical prostatectomy. I'm going to go over the issues surrounding the topic, inform you of recent papers which help elucidate the natural history of this disease. There are a few new techniques that help us localize where the recurrence occurs, either in the prostatic fossa or at metastatic sites, as well as go over some recent articles on treatment options. In Canada, 10,000 men a year are diagnosed with prostate cancer. 4,000 men a year undergo radical prostatectomy. And about 25% of these men over 15 years, and really probably over 5 years, will have a detectable PSA after prostatectomy. And although many of these men have biochemical recurrence, we know now that most of them will not progress to have metastatic disease and die of prostate cancer. And several articles have shown that biochemical recurrence in itself does not alter the survival rate of this population. When a prostate is taken out for localized prostate cancer, one can expect that the PSA should decline over 21 to 30 days to an undetectable level. If one considers that after 7 half-lives, the PSA should be less than 1% of its initial value. After surgery, when a PSA becomes detectable, the most likely cause is tumor recurrence, either locally, metastatically, or both. But other reasons can cause a rise in PSA. False positives occur because some non-prostatic tissues secrete PSA, like the periurethral glands, salivary glands. As well, with the advent of ultrasensitive PSA tests, patients have a PSA detectable at 1/10,000th of a nanogram per ml, making patients who were cured and with PSA undetectable disease now rendered PSA detectable at very low levels, possibly not representing recurrent disease at all. And as well, it is possible that there's residual benign prostate glands within the prostatic fossa after surgery. A study has shown that 27% of specimens will have benign prostate glands at the resection margin. And this would suggest that there are benign glands left within the prostatic fossa. As well, when patients undergo trust biopsy of the urethral or vesico-urethral junction after surgery, about 15% of these patients will have some benign prostate glands in the specimen. Ectopic prostate tissue also has been written about in the literature. Apparently, you can find ectopic prostate tissue perivesically, or even as far away as the spleen. This was an interesting case that Dr. Klein told us about in academic half day or at professor's rounds. He had a patient who had a radical prostatectomy 5 years previously, and after several years, the patient had a rise in PSA I think he said about 0.3 to 0.4. And when he performed a DRE, there was a mucosal nodule within in the rectum, and he had GI medicine remove it, and they removed the nodule completely. And it showed on pathology to be a focus of prostate cancer, Gleason 3+3, was margin negative within the submucosa of the rectum. And after that point, the PSA became undetectable. And he asked us, so how did that prostate cancer metastasize to the rectum? And he felt that it was probably because of the trust biopsy seeded the tumor across the mucosa. So although this is very, very rare, this can occur. So PSA after surgery has been said to be the best clinical marker for disease progression. It is undetectable in patients who are cured of their prostate cancer, and it rises in almost every patient who goes on to have prostate cancer progression. But there are a lot of problems with using PSA as an intermediate marker for disease progression. First of all, not all patients with biochemical recurrence will die of the disease and progress to metastasis. From the natural history series, we know that many patients do not progress to metastasis, although this probably causes a lot of anxiety for patients who have to follow their PSA elevating visit after visit in the clinic. We don't have any good imaging techniques to localize where the recurrent disease occurs, whether it occurs locally in the prostate fossa or metastatic site, and this, of course, would help us guide treatment. As well, PSA has not been validated as a surrogate outcome marker for prostate cancer. Interventions that alter PSA level may not correlate with an altered survival benefit. And that is the problem with using early hormone therapy for the treatment of a rising PSA. We do not know whether or not hormone therapy alters survival, and there are no randomized control trials using hormone therapy in this specific clinical scenario. So the definition of biochemical recurrence is any detectable, generally is any detectable PSA or rising PSA after primary treatment. But we don't have a standardized consensus on the definition of PSA rise after prostatectomy. The definition ranges between 0.2 to 0.6. The ASTRO criteria have created a standardized definition for a rise in PSA after radiation therapy, and this helps standardize studies, but we don't have that yet for radical prostatectomy. So this series from the Mayo Clinic showed that patients who have a PSA of 0.2 after prostatectomy, only 50% of these patients have an ongoing rise in their PSA. And they recommended that a PSA of greater than 0.4 be the best level to consider treatment of their recurrent disease, suggesting that 72% of these patients will have an ongoing rise in their PSA. And this data is also supported by Pound's data, where he used a cutoff of 0.2, and 50% of those patients had an ongoing rise in their PSA. An important point is that patients who have biochemical recurrence, almost all of them occur within the first 3 to 5 years after surgery. In this series by Hall of 1,000 patients with 15% having recurrent PSA, almost 50% of them occurred within the first year, suggesting that they were understaged at the time of treatment and had residual disease after treatment. In his series, none of his patients had PSA recurrence after 10 years, but in other series, of course, this can happen. Okay. So there really are only two or three natural history series describing what happens to PSA after radical prostatectomy. And this is because patients now who have a PSA recurrence tend to get treated. And so the landmark paper was described by Pound, published in 1999 JAMA. And what he did was he did a retrospective review of 2,000 patients who underwent radical prostatectomy and followed them for a median of 5 years, and demonstrated that only 16% of his patients had a rise in PSA during that follow-up period. And what was interesting about this paper is he showed that the time to develop metastasis was quite protracted. It was a median of 8 years before a third of these patients, a median of 8 years before they developed metastasis. And that only occurred in a third of patients who had a rise in PSA. He also showed that after development of metastasis, it took 5 years before half of these patients went on to die of their prostate cancer. And this is important because it gives us an idea of what happens when you don't treat PSA after it rises after prostatectomy, and that the natural history is actually quite long. And this is also a slide or a graph from his study. And in 2003, Parton published an update to his series. He added 100 extra patients to the Pound series and had a longer follow-up, and showed that, again, it was about 7.5 to 8 years before half the patients developed metastasis, further validating Pound's study.
That's if they have PSA 0 after surgery.
They didn't say how many patients had a PSA 0. They just said that patients who failed surgery and had a rise in PSA above 0.2. So it may have happened right after surgery or delayed. And it was quite a heterogeneous group of people. But the median was 8 years. And I'll show you on this next slide that he was able to stratify patients into high or low risk, whether or not they would develop metastasis. So even though people have a biochemical recurrence after prostatectomy, many of them don't develop mets and many do. And what he was able to show was that if they had a Gleason of 8 to 10 on the pathology, if the biochemical recurrence occurred under 2 years, and if the PSA doubling time was less than 10 months in his study, that they were at high risk of developing metastasis. And those patients, at 7 years, 80% of them had metastasis. And if you didn't have any of these high-risk features, 80% were met-free at 7 years. So he was able to stratify patients into one group or the other. And that was a univariate analysis. In Parton's update of basically the same patients plus 100 patients, he showed the same thing, but time to biochemical recurrence no longer seemed important on his univariate analysis. It was just Gleason score and PSA doubling time that appeared important. Now, Roberts published a very similar natural history series in 2001 and performed a multivariate analysis, and it was only PSA doubling time that predicted metastasis in his series, and that seems to be the most consistent factor, and his was a PSA doubling time of less than 12 months. Pathologic.
Yeah. What's the natural history of this? Is the median of 8 years metastatic disease? And then you look at grade and doubling time, etc.
Yeah.
What's the natural history of prostate cancer untreated?
Yeah, well, I guess the best natural history series is by Albertson, where he didn't have Gleason. He only had stage criteria. Oh no, he only had Gleason and stage, but not PSA criteria. So it's hard to tell. But for someone with a Gleason score of 8 to 10 in his series, a third of them went on to die. I guess it was a mortality series.
The question I asked was, this is information about the natural history of PSA recurrence, and then they stratified for grade and doubling time and time at progression. Overall, the median progression here is at 8 years. And the question I asked is, what's the natural history of untreated prostate cancer when you stratify for the grade?
So what happens?
Quite a number of really out series that produce what's the name in the States? United Care Group and Albertson showed activity showed I did a review of meta-analysis of all the series around the world, and it was every single one showed the same thing. The patients with either high grade or Gleason greater than 7 progressed all progressed in 6 years without within 5 years and without a third of them was dead.
The high grade is similar to what you just said about this.
Yeah.
So my memory of the natural history.
And the low grade ones, less than 7, very few. You're talking 5-10% death rate.
Right, naturally, yeah.
It has the same flavor as the natural history.
It does, yeah. So is surgery doing anything when we treat someone with high grade cancer or low grade?
Mm-hmm.
That's the big question, which I'm not going to answer.
But this data looks very similar to the natural history series to me.
It does, yeah.
If you assume that there's a whole pile of people who
That's a good point.
That
84% of them
they never even had a PSA recurrence, right?
This is all about 16%.
The patients that were cured, his series was interesting because almost all of them were Gleason 6 and Gleason 5, and they were very low-risk patients.
The question is, do we need to be treating them? Not these. I think the ones with the high-risk cancers are the ones that we're trying to do something for. Unfortunately,
and we might not be.
For a lot of them, it's reflected.
Well, that's not a lot of them. I mean, we can't go on to 16%.
No, 60% of all of the patients. But what I think I missed the slide and I have about what percentage of patients of the original 2000 had high risk disease?
Well, it was very, very low. Yeah, it was. I can't remember exactly. So maybe they all progressed, and we don't know that. I guess.
Even in anyone's series, mine included, your Gleason 8 to 10 is a very low percentage of your patients. Most of these are Gleason.
We probably have a higher percentage of surgical patients with Gleason 8 to 10 as well as because we tend to be more aggressive.
Yeah, but a lot of it still is very
hormone therapy.
Yeah, it's about 15%, I understand.
15%.
15. Oh, I don't know about this hospital, but.
You're right, though. In general, it's a smaller percentage. People don't tend to operate on these treatments.
Those young guys with high Gleason scores, instead of go for it, instead of treating aggressively, they will send nothing else off them. And recording this doesn't matter what you do. Well, but that's the PSA and the detectable is 80%, right?
85%, yeah.
But what you don't have here, Andrew, from a natural history point of view, is if you looked at just patients with Gleason 8 to 10, and you're analyzing the surgery and non-surgery, how long the date. So that's what you don't have. So you're comparing. You can't compare.
Yeah, that's true. And even Albertson's data didn't even include PSA. Like, it's hard to compare his national
Albertson's data
with Gleason and so we don't have PSA as a factor. So what I wanted to mention here was that once patients developed clinical mets in his series, they went on to die, as I said earlier, at a median of 5 years. And even this group is a very heterogeneous group. There was a recent paper published by Shulman in Journal of Urology 2004 who looked at patients who had hormone refractory prostate cancer and found that you could stratify these patients into high, intermediate, or low risk categories. And that they all, in Campbell's, they say that patients with hormone refractory disease go on to die at a median of 12 to 18 months. But really, it's quite, it can be stratified. Patients who had a doubling time while they were hormone refractory less than 6 months, PSA nadir on hormone therapy of over 0.5, and a time to progression on hormone therapy less than 7 months, had only a 14-month median survival. But if none of these factors were evident in the patient population, they had a 90-month median survival while being hormone refractory. I don't know how many patients have that clinical scenario, but I thought this paper was interesting because it further showed us risk stratification of a natural history, a group of patients who have prostate cancer in their natural history. And in the box below, you can see in an article published in 1999 that biochemical recurrence does not really predict anything. In a population of patients who have biochemical recurrence, they had the same 10-year overall survival as patients who didn't have biochemical recurrence. And the problem is that patients who are treated for prostate cancer and followed have competing comorbidities that can cause another form of mortality. But what we can say is that over 10 years, about 25-50% of patients will have a PSA recurrence. About a third to a half of these will progress to metastasis, and 10% of patients overall who have a radical prostatectomy go on to have a prostate-specific death. And the reason I brought this up was that there was a paper published in the journal Urology by Albertson, who attempted to stratify patients after surgery into high and low risk categories to dying of prostate cancer. And he showed that if the PSA doubling time was over a year, or if the PSA didn't rise, that they were at low risk of dying of their prostate cancer within 10 years. And the patients who died of prostate cancer had a PSA doubling time of 8 years or 10 months. And this was statistically significant. So again, PSA kinetics can help with predicting which patients are going to progress on in their disease. And I just wanted to put up the slide to let you know how PSA doubling time is calculated. It's this complicated formula which Kevin hates. So there's actually a program that you can download for your Palm Pilot. You plug in the PSA numbers and they calculate the PSA doubling time for you. So, yeah.
Go back a second. The final PSA is, what does that mean?
So,
what level is it?
So it's a logarithmic scale.
No, I understand that, but when do you call it the final PSA?
Today, yeah, the last PSA.
The last PSA.
Yeah, minus the previous PSA.
And the PSA is pre-op?
No, at any point. It's just looking at the slope of PSA change.
T is time
In months, yeah.
between the final and the initial.
Yeah. And this is only using 2 PSA points.
Between 2 PSA points,
Yeah.
doesn't matter which one. You can do a doubling time over a year. You took 10 PSAs that year. You can do it over 10 years. You had one per year. Doesn't matter.
And the PALM program is good because you can actually put multiple points and then they somehow calculate some sort of slope, which is probably more accurate.
The problem is you measure the two slopes 1 month apart.
Mm-hmm.
Then your measurement area
Is too high. Yeah, that's true.
It's a big part of the practice.
So one important point is that it's hard to differentiate. Well, it's not hard, but people consider that PSA recurrence might be due to residual benign disease after prostate cancer. And although there's no really good studies to help you differentiate between the two, some investigators have published papers with their opinion on this topic. Foster in 1995 stated that with benign prostate, PSA usually rises and then levels off, whereas cancer would cause a steady continuing rise in the PSA, reflecting what we would expect from PSA kinetics and cancer cell growth. And Ravery published in 1999 that even if the post-op TRUST biopsy documents benign tissue only, PSA kinetics would suggest that it's highly unlikely that the detected PSA is due only to the benign tissue, but malignant tissue must coexist. So it's something to keep in mind that if the PSA continues to rise, that one should really consider that it's probably due to prostate cancer recurrence. Two series published the site of recurrence.
Was that based on anything other than?
No, this is opinion, and there were 3 authors that said the same thing. When I looked at the topic, they all sort of said the same thing, and there was no contrary viewpoint. So it's pretty well impossible to study.
going back, that's not what we're talking about today. That's benign disease.
Yeah.
So
No, that's what you do with trust biopsy.
it's benign. No, but we're talking mainly today about recurrence.
Well, some people.
If somebody has a PSA recurrence and you biopsy their anastomosis and it's benign disease there, and the patient would say, okay, well, it's just benign tissue, but their PSA continues to rise. Is it benign and malignant?
So you have benign prostatic hyperplasia as anastomosis?
Yes, yeah.
So therefore you left part of the prostate behind.
Sure. And that's very common.
Well, I've seen it. No, I have. I'm serious. I have not seen that. Have anybody in this room seen that? You?
I haven't.
You've got to be kidding.
And there's a series that shows that 15.
We treated with being biopsied 3 times over about 5 years for a nodule, and it's always benign. But if PSA is now 6 or 7, it's benign.
So you mean you must have left part of the prostate behind?
Maybe a little lobe or subtrichal lobe or maybe.
And it's very common. 25% of specimens apparently have. Yeah. Okay.
I've done a few, and I thought one patient was driving me crazy.
So, but I mean, I've seen recurrence of cancer.
Yeah.
But we're talking anecdotes again.
Yeah. But there is a series that showed that 15% of post-op trust biopsies only have benign prostate tissue in them. So there is a series to support that finding. When prostate cancer recurs, about a third of the recurrences have been found to be solely local recurrences, and about two-thirds of recurrences involve distant metastasis with or without a local recurrence. And in hand series below, you can see that about 50% of the biochemical recurrences were only PSA recurrences over time. And I just wanted to put that out so that I would know that local recurrence is also still an important part of recurrent disease after prostate cancer, even after the prostate has been taken out. So part of the dilemma is trying to figure out where the prostate cancer is recurring after the PSA goes up. And the problem is that none of the imaging technology available today accurately localizes prostate cancer either to the prostate fossa or to metastatic disease at a PSA level when radiation or salvage radiation would be a good treatment option, a PSA of 1 or 2. DRE is no good. You can't differentiate between scar and cancer. Trust biopsy has been shown to have little role after radical prostatectomy since the results have not altered the outcome of radiation. Even when it shows a positive cancer in the biopsy or negative for prostate cancer in the biopsy, it does not alter the results of salvage radiation therapy. CT scan requires a nodule of at least 2 centimeters before it's positive, or PSA about 10 or 20. PET scan is useless. It doesn't differentiate between scar or local recurrence. And just jumping to the bottom, bone scan also is not useful because only less than 5% of scans are positive when the PSA is less than 40 to 45, and if the PSA is about 10, only 1 to 2% will be positive. Endorectal MRI is under investigation. I haven't found any articles on that yet, but apparently MSK is... Oh, has he? Okay. I'll look at it again. I know that Dr. Scardino mentioned that they have a series going, but it hasn't published yet. Anyway, and Prostate is interesting because it has been approved by the FDA in the States in 1998 for the use of detecting prostate cancer after radical prostatectomy. And to summarize, it's basically an antibody, a monoclonal antibody, which is specific for a protein found in prostate cancer epithelial cells as well as benign epithelial cells. And it was approved back in 1998 based on some sketchy evidence. And there's an article that was published recently in July 2004. And what these investigators did was they had a series of 36 patients who had a rising PSA after prostatectomy and found that 85% of these patients did have a positive prostate scan. And what they did in their series was they tested the patients when they only had a PSA of 1.2. And even then, the prostate scan was positive in 85% of patients, which is pretty good because the previous series tested prostate when the PSA was way too high, about 10 or 20. In 15 patients who had a positive scan only in the prostatic fossa, these patients underwent salvage radiation. And what he found was that after 30 months, 47% of these patients had ongoing undetectable PSA after salvage radiation. And what these authors concluded was that prostate probably isn't useful because even when you look at salvage radiation series that don't use prostate, the success rate is in the same range of 40 to 50%. So it isn't a real trial, but really it looks as though prostate did not alter this group of patients' outcome. But it's interesting.
Do they have a control group of patients?
No. It's just a series of patients that they treated.
But you can't have anything about it.
No. And it's impossible. Yeah.
There's a large prostate trial group that was
there,
done
yeah.
by Allen Park, much larger numbers than Minnesota.
Yeah.
And showed about really no effect, there's no differentiation. So they abandoned the prostate. And now, Phil from New York has developed the more specific
antibody? Oh, okay.
PSA membrane antibody.
The problem with this antibody is it targets the membrane inside the cell, and this one targets the same antibody or antigen outside the cell. So maybe there's some promise. I don't know.
What about rectal examination?
They say that you can't differentiate between sort of changes in scar and changes in recurrent tumor, and then the time that the tumor grows and you can feel it, the PSA is probably too high to treat it, say, with radiation therapy.
So the patient comes to you post-radical prostatectomy for follow-up. You know, I follow my patients for that period of time, radical prostatectomy. Would you do a rectal exam or would you just talk to them on the camera?
I think we just...
Would you bring them back to your office, or would you just get your computer out and say...
Your PSA is undetectable.
Would you do it all by email?
Well, I think I would see the patient to talk about the disease, but...
PSA is undetectable. I mean, Salvage did that large review.
I know that.
If PSA is undetectable, DRE doesn't pick up any local recurrence in the absence of the rising peak. In the absence of a detectable PSA. If you have
all
a
patients that are recurrent have to have a rising PSA?
They almost all of them.
Yeah.
Almost.
It'd be pretty rare to get a nodule without a rising PSA, and that was not a Salvage review, and I think most people would experience if you stand on Earth, you have a big...
Occasional patient has high-grade disease, very low PSA, and those are the guys that really have. But that's pretty rare. It's
very unusual. Well, I don't do DREs on people with undetectable, but once you have a detectable PSA, you have to do a DRE.
It's amazing how few people do it.
Mm-hmm.
I mean, I don't know the thing is, you recall.
The thing is, you don't get the PSA before you see the patient, do you?
No.
So you get your office and you go, how are you?
We do. A couple weeks before.
You do? You tell them to go get it?
Yeah.
And they come in.
So if the PSA is undetectable, then you don't have to bother.
Yeah, but I mean, but still, maybe how many people do even detect. Start doing all these tests every minute. I see a lot of different people.
A lot of the imaging tests, with the CT and...
Anybody examine it and say no?
Several series have published the results that help us localize whether or not the recurrence has occurred locally or metastatically based on clinicopathologic features, since imaging to date has not been very useful. And I'm not going to go over all the specific studies, but patients who have local recurrence are more likely to have local recurrence if their PSA doubling time is over 6 months, if the time to recurrence of their PSA was over 2 years. And whether or not positive surgical margins indicate a higher likelihood of local recurrence is somewhat controversial still, but I'll show you a recent article on that. And patients are more likely to have metastatic disease if the PSA doubling time, and it comes back to PSA kinetics, is less than 6 to 10 months, if the recurrence occurs in less than a year or two, Gleason 8 to 10 disease, if the pathology on the specimen shows positive lymph node involvement or positive seminal vesicle involvement. And this is pretty intuitive as well. Now, whether or not positive margins on a radical prostatectomy specimen predicts for local recurrence has been controversial, and the top sentence there is from a series where they say positive margins are not essential for local recurrence, because what they found was that patients with local recurrence, about 30% had negative margins on the specimen, and about 15 to 50% of patients will have organ-confined disease on pathology. But there's another series which looked at these patients and re-reviewed the pathology. And they showed that 92% of these patients were then converted to a positive margin status when the prostate was further examined. So maybe our pathology isn't accurate enough to determine margin positivity. And then on a multivariate analysis was published recently in JAMA 2004 by Stevenson, who performed a salvage radiation series. And he showed that a multivariate analysis, when the margin status was negative, this predicted for poor outcome after salvage radiation. And this was an independent risk factor, suggesting that positive margins predict for response of salvage radiation therapy and therefore local recurrence. Yeah? Well, I think that the top series is just a completely different type of study. The top series was just looking at their positive margin rate, retrospectively looking at the series of pathology, and then looked at the series of patients who appeared to have local recurrence, probably on CT imaging, or because this was from the 90s, and showed that there was no correlation between the old pathology and what they saw on CT imaging. But this bottom study, I think, is a little bit more valid because they actually treated the biochemical rise with salvage radiation therapy and saw that there was a correlation with response and the positive margin status. So I feel that's more valid. I don't know what you think. Am I jumping to conclusions? I have a slide on it, actually. It's like a whole group of people that were involved in the study. Klein was involved in the study, and Scardino, I think.
Oh, that one. That was Klein too.
Stevens? Yeah, I think it was.
That one was in the headline.
I have another.
Salvage radiation. I know that they had to look.
I'll show you a slide on it in a moment, actually. And so, in terms of treating biochemical recurrence, we can, of course, do nothing and watch it, observe, and treat later. And that would make sense from Pound's data. We can probably stratify patients who are likely to progress and those that won't. There's the option of salvage radiation therapy to the prostatic bed. As well, people treat biochemical recurrence with early androgen withdrawal therapy, although there really aren't any randomized controlled trials that support this specific clinical scenario. And just to review quickly, salvage radiation therapy, there has been consensus guidelines published by ASTRO in 1999 for the treatment of PSA recurrence that you think occurs locally in the prostatic bed. And what they suggest is that salvage radiation therapy must be given before the PSA reaches 1.5. And data would suggest that a level of 1 or 2 be the cutoff at which salvage radiation therapy is the most beneficial. They recommend a radiation dose of greater than 64 gray. And at this time, there is no data to support the use of neoadjunctive hormone therapy or adjunctive hormone therapy to be used for salvage radiation therapy. And the cutoff of 2 is important. It seems early because we'd like to follow patients for a long time, and it seems like we have to act fairly quickly. But when people had a PSA less than 2, 83% of these patients were rendered PSA-free after salvage radiation therapy. Whereas where patients had a rise in PSA above 2 and were treated with salvage radiation therapy, only 33% were rendered PSA-free. And what I'm going to show you here is a summary of that article that I just summarized by Stevenson in JAMA 2004. And what he did was he had it was also a non-controlled retrospective look at his series of 500 patients who underwent salvage radiation therapy for a rise in PSA. And it was a rise in PSA over 0.2, is what he just defined as biochemical failure. And the follow-up was 45 months. And what he showed in the overall series, which is consistent with other series, the 4-year progression-free survival was 45%. And then he performed a multivariate analysis looking at several different factors and showed that if a patient had a high Gleason, pre-radiation therapy over 2, negative surgical margins, PSA doubling time less than 10, or positive seminal vesicle invasion, these all were predictors of progression after salvage radiation therapy. And if none of these features were evident, they had a 77% PSA-free survival. He also looked at, there's some controversy as whether the cutoff should be 1 or 2. I think Dr. Glees feels fairly strongly about cutoff of 1, he mentioned in clinic. But in this series, they compared the group of patients with PSA less than 1 and those between 1 and 2 and showed that there was no difference. It may have not been powered to show that difference. And this is the important point with the surgical margins because they were able to show that it independently predicted for progression. Another approach to biochemical recurrence is treatment with early hormone therapy, and there are no randomized controlled trials yet to support this, although there are series trials that have shown that early hormone therapy in different clinical scenarios can delay or prolong survival and delay metastasis, such as BOLA series, meshing series treating hormone therapy for lymph node positive disease. But I did want to show you this series, which is strictly an observational series again, but Moll published this in 2004, where he compared patients. He had 1,300 patients who had biochemical recurrence after prostate cancer, and about a third of his patients had early hormone therapy before the PSA was 10, and another 2/3 or 3/4 had no hormone therapy until the PSA was over 10, and really most of them had no hormone therapy until metastatic disease. And what he showed in the overall cohort when he compared the time to metastasis was that there was no difference in that time, whether or not they had hormone therapy early or late. But in the subgroup of patients who had high-risk features, Gleason over 7, or doubling time less than 12, they had a delayed time to metastasis if they had hormone therapy before the PSA was 10. And he also did the analysis of a PSA less than 5 and showed a very similar difference in time to metastasis. And they didn't conclude any recommendations for early hormone therapy, but said this was hypothesis generating and suggests that high-risk disease may be treated early with hormone therapy.
But again, what I
Yeah.
think out of that is
Yeah.
very important is the doubling time. The absolute single value of PSA at any time
It's not important,
doubling
yeah.
time is much more important.
It's like your guy with
Nick and I reviewed this a long time ago in our cases. The patients who have a very flat curve of doubling time without hormone therapy, 10 years later, almost all of them still have a low PSA, really detectable. But those of them with a doubling time less than 12 months, they continue to rise exponentially.
Yeah.
So
this is
even though it's not
yeah.
under my theory, that is an observation. It's still
very interesting. Yeah.
What are you going to do with a guy that has that high-grade disease, positive surgical margin, but undetectable PSA?
Yeah. So, what Campbell says that in itself is not an indication for, say, radiation therapy. That many of these patients never go on to have a PSA rise.
What's the margin?
Well, like a real positive surgical.
A real one?
A real, not just a...
But Scardino says he does radiate some patients like that.
Like flat
So,
neck and eight?
No, like an apex, a real margin on a baseline. Not just a focal. I think for young guys, I think they would benefit from it. For 8 to 10, even have
I think Scardino said he's doing that, isn't he?
Pardon? Morbidity is
But,
pretty high. I did radiotherapy after a radical, but I negative PSA and have a hard time stopping it.
yeah, that's true.
If you have seminal vesicles involved, negative lymph nodes, negative seminal vesicles, I go back to what it was like at the time of surgery. You've got a causal apex, and it was very difficult at the apex. You have the feeling of your cancer there, and the plate going into your region. And you see those high-grade tumors every once in a while. They're pretty nasty at the time of surgery. And then I would radiate that guy very soon.
It's almost like multimodal therapy for high-risk disease as opposed to...
clean radical, and I wouldn't.
I think you're in there right. But the ones that are real positive, you know that there was a problem at the apex, there was a problem for that.
Okay.
This is strictly a gut reaction.
No evidence.
No data.
Sure.
This is a large European randomized trial application for radical toxicity where you're describing adjuvant radiation for non-PSA, that's PSA, PSA, but most of this native at seminal vesicles, positive margin, vascularization.
Right.
And for the thousand feet, sort of 20% biochemical advantage to early radiation overall. Now, I was just looking at the margin.
Yes. Yeah.
They also did a 2-year urinary quality of life follow-up, and there was only about 5% of patients that increased in body.
Yes.
I don't think that's morbid.
As you would think.
That's a big issue with morbidity. I always hesitate. In the past, I've hesitated to send patients who have had a good result from the radical for radiation. Does everyone know Scott Johnson? One of the radicals.
Hi.
That's where he's attending. But you know, as you guys get better at delivering that radiation therapy with morbidity, I'm more inclined now to send patients from a quality of life point of view, who are sort of like, you know, maybe in the past I tend to wait a little bit longer. Now I'm sending earlier.
In my experience, radiation isn't that morbid after prostatectomy.
Radiation therapy is more coming out from the radiation oncology.
Oh, good. Excellent.
Getting back to this, so hormonal therapy, much radiation therapy in this patient that has been sent for radiation therapy, that has no difference.
It has not shown that. In Stevenson's series, I didn't show that here, but he also included patients in his multivariate analysis who had neoadjunctive hormone therapy, and there was no benefit to having neoadjunctive hormone therapy in his series. And then there really aren't any other series that I know of that have addressed the issue. It makes sense based on Bullett's series. What would he? Yeah.
Well, there's one randomized trial that 8531, there's a subset of about 150 patients that all of them had radiation. They randomized to definite antigen ablation along with that. It was about a high-risk patients, but there was a subset that was rather prospecting. In that subset, there wasn't survival with the story. After the bile management, slight biochemical damage to the hormone therapy, but I think the consensus is not a bit of data. There was a big randomized trial finished about 2 years ago where everybody got radiation, and there were 2 years of adjuvant catherectomy, and that's how we do it.
Oh, okay. So it's evolving. So what I learned from reviewing this topic basically reflects what I learned in clinic, really, is that every patient with biochemical recurrence is different, and that you have to take a risk-stratified approach. And that the guidelines really aren't there, but I think I've reviewed all the different options, and just taking into account the natural history and risk factors for recurrence in that specific patient. Side effects of therapy are important, which I didn't really go over, as well as that patient's quality of life and life expectancy in deciding what the best approach is. And this last slide just goes over some other options that are sort of in development, and other options that one may think about, which is anti-androgen monotherapy. There have been some step-up hormone therapy regimens that have been suggested for experimental this time, starting with a 5-alpha reductase inhibitor and progressing to an anti-androgen, and then LHRH and on. And intermittent hormone therapy is also currently being studied in a randomized controlled trial. Oh, is there? Is there a PR8 that is looking at this? Or is
metastatic.
Oh, sorry. Okay. So, but
there was a series in Seattle, small series of genetic therapy.
And what did he find? Okay. So that's another step that people take even here for this. So that's basically it.
When do you decide to use it? Well, there's two issues. When do you use hormone therapy? Once you decide to use hormone therapy, then you use continuing for intermittent. And I tend to use intermittent outside of clinical trials because so far, as far as we can see, the efficacy is at least equal to continuous therapy. It's got all the upsides of getting patients on therapy. I may eat my words one day if we ever have randomized studies showing that intermittent works. But until we have that data, I tend to follow the side of it's at least equal, maybe it's better.
What about the side effect profile of intermittent?
The quality of life theories are now coming out. In fact, Nick is just going to show you. He's got 100 patients, and he shows an advantage, quality of life advantages. Someone from San Francisco, I can't block on his name, he's done a quality of life assessment and has shown they're not huge differences, but there are improvements in quality of life in the patients. And there's a fellow from Australia who's also done a quality of life assessment and has shown a difference. So there's these phase 2 studies that are showing differences, improvements in quality of life, But the ultimate test will be the CR7 and the CR8 because the large randomized series. Hopefully one day we'll have that.